Vrijeme je za još jedan panel, važnost prevencije kardiovaskularnih bolesti u pandemiji i utjecaj na državni proračun. Izvolite.
Good day to everyone. Welcome and thank you for joining me on this round table regarding cardiovascular diseases. Let me at the moment introduce everyone today. I thank you and welcome Professor Davor Miličić, President of Croatian Cardiology Society. Hello, Professor.
Morning, hello.
Morning. Professor Željko Reiner, President of Croatian Society for Atherosclerosis. Good morning, Professor Reiner. Mr. Haseeb Ahmad, Global Head of Value and Access and Commercial Development, Novartis.
Morning.
Morning. And Ms. Anne Arts, Head of Novartis Foundation. Good morning, Mrs. Arts.
Good morning.
Good morning. Good morning. And let me just read the short introduction on our team today. Cardiovascular disease is a group of diseases that collectively are the world's biggest killer and cause of disability. 1 in 3 people die from cardiovascular disease. Indeed, there is a higher chance of dying from CVD than cancer. Heart disease is the most common form of cardiovascular disease, while strokes are the second one. When arteries that pump blood around the heart and to the rest of the body become narrow due to deposits of plaque on artery walls, it is known as atherosclerotic cardiovascular disease, or ASCVD. Bad cholesterol is a major risk factor for ASCVD, together also with other risk factors like smoking, hypertension, diabetes, obesity, etc. As it interacts with artery walls to create a thick plaque that narrows the arteries and prevents normal blood flow, leading to heart attacks and stroke. Preventive measures against LDL is a cornerstone of countries' responses to CVD. Statins are the primary method for reducing it and have been around for almost 40 years. Today, more than 200 million people worldwide take statins. Among the group of people who need preventative medicine are patients who have already had a cardiac event and survive and are also at a high risk of another event. Professor Miličić, after this introduction, what is the situation regarding cardiovascular diseases in our country? Is it also killer number 1 in Croatia? Where does it rank?
Yes, definitely it is. From the last year, we have the newest data, which tell us that in Croatia in 2019, cardiovascular death was in 22.5 overall mortality. So it is still the leading cause of death, but during the last decade, we can observe a kind of decline in mortality of cardiovascular diseases in Croatia, because it was about 55%, and the recent data show us 22.5, which is in one hand satisfactory.
42.5.
42.5, yes.
Yeah, it's not 22.5.
No, 42. No, thank you. Yes, 42.5. So that is more than 10% of decline in mortality of cardiovascular disease. That means that if we compare Croatia with Europe, in Europe, data from 2017 show that cardiovascular mortality was 45%. So in that way, we are a little bit below the average mortality from cardiovascular disease in Europe. But regardless, Croatia is officially declared by the European Society of Cardiology still as a country with high cardiovascular risk, because of the lifestyle of our population and because of the fact that cardiovascular mortality is still far leading among total deaths.
The numbers are better, but not still fine.
We can't be satisfied with these numbers. We have a lot of things to do to reach about 30% of mortality.
That is some goal.
Yes, yes.
And what are the Croatian main cardiovascular problems?
Of course, as elsewhere, the most important and the leading cause of death is myocardial infarction. Then on the second place is stroke, and then other cardiovascular diseases. Heart failure is also an emerging problem, not only in Croatia, but all over the world, because more and more people survive myocardial infarction. If not treated on time, and that's quite often the case, then they develop usually what we call ischemic cardiomyopathy, and they start with their problems due to chronic heart failure, which is a progressive disease and brings many problems. Atrial fibrillation is another important problem within cardiovascular pathology. I wouldn't say mortality, but pathology. It's a quite frequent arrhythmic problem. We can treat it nowadays much better than 10 years ago. There is an excellent interventional approach to treat heart failure, to treat atrial fibrillation. So that is the case. And one more thing I would like to mention is aortic stenosis, which is the most common valvular disease nowadays, growing in its incidence and prevalence because the population is growing, and these degenerative diseases are also reflected on cardiac valves, and aortic stenosis is typical for the older population. And the good thing is that in the oldest people with that deadly disease, nowadays we can treat it without classical surgical approach, because there are interventional procedures that could implant aortic valve percutaneously. So that is a great advantage of technology and cardiological skills.
Do we even know how much we spent on treating cardiovascular diseases as our main health problem in Croatia?
I can't say you in concrete numbers, but I would say that despite the fact that contemporary medicine is expensive, in cardiology, cost-benefit ratio of these costs is quite affordable, because we have to take into consideration that we are treating people usually in their middle ages or not very old from myocardial infarction very successfully. So after the intervention and 2 or 3 days in the hospital, they start a normal life. Of course, they have to obey all the rules of secondary prevention, but they can return to work very quickly. They can start with their normal social life, mostly as before, and that is a great advantage. And all the other procedures in cardiology are not so expensive regardless cost benefit. And last but not least, medications in cardiology are extremely important. They are not just improving symptoms, but they are literally, some of them, prolonging and saving lives. And these medications, in comparison with medications in other fields of medicine, are in fact quite affordable. From antihypertensives, which are very cheap, to statins that are saving hundreds of thousands of lives all around the world. Someone has calculated then in Croatia, 1 year on statin treatment costs not more than 100 euros. So 100 euros per year, taking such effective medications, that is really, really very much affordable. Of course, some newer medications and some newest medications, such, I don't know, PCSK9 inhibitors, are relatively expensive, but also you have to think how big the benefit out of these medications can be brought to a patient. And that is very impressive. So I would say that treating methods in cardiology are very much affordable.
Very much affordable. And
yes.
How does it look like the cardiovascular patient journey through our healthcare system?
Our healthcare system is a public healthcare system, which is very good for our patients because practically they don't have to co-pay. They don't have to pay and they don't have to co-pay. And they can get everything from medications, the newest medications according to some agreement between cardiologists and our National Health Fund. But very good example is, for instance, the most expensive probable treatments in cardiology, and that are heart transplantation, heart pumps, operations due to congenital heart disease, TAVI procedures. I was talking about treatment of aortic valve stenosis via percutaneous approach. So all these methods are available for our patients, and they don't have to pay. They don't have to pay for left ventricular support pumps, which charge our system more than 100,000 euros per pump. So everything, in fact, is available and everything is free for our patients. Of course, we pay a lot of taxes and we pay a lot to our health system, relatively a lot if we consider the brutto amount of our salaries. So substantial part of that goes to taxes and for the health system. But another thing is that you can never have enough in health system and medicine because it is becoming more and more expensive. But at the moment, I would say we are still in a position to assure everything for our patients, literally free of charge for them at that moment that they need, when they need therapies. And that is very good. The waiting lists in Croatia in cardiology are not long as well. So if you need elective coronary angiography and intervention, if necessary, now, despite of this pandemic, you wouldn't wait more than 1 month or even less. In our institution, it's less. So that's great. If you are waiting for a complex, very expensive TAVI procedure, the waiting time is about 2-3 months. If you are urgent patient, if you need immediate intervention, you will get it in a couple of days. Mm-hmm. So there are no long waiting lists for cardiology patients, and that is very good because many of them are not very chronic. Many of them need care from in short time periods. And I think, generally speaking, our cardiology is quite on high level.
Okay, thank you and congratulations. Now let me ask Professor Reiner. Probably not the same, but all of this that we heard till now regarding cardiovascular patients in Croatian healthcare system, is this COVID-19 situation changed something?
Well, obviously, as in almost all countries, it does have its effect on treatment of cardiology patients. And according to the data, we, since the beginning, particularly in the first wave of COVID-19, there were, according to the numbers, 14% less MIs, myocardial infarctions, mm-hmm. which probably does not reflect the fact that we suddenly became much better or our patients suddenly became much healthier than they were last year, for instance. But it probably reflects the fact that those patients who have non-STEMI, for instance, or of course who are in relatively good condition, tend to hesitate to come to the hospital. And this is a reality which is something that we are not very happy with, but it's understandable. It's understandable, and it's quite similar with some other diseases where patients, as I said, are hesitant to come for help to the hospitals, being afraid of getting COVID-19. And certainly, if a cardiovascular patient is affected by COVID-19, his or her situation is not the same as it is for a young, healthy person. So this fear is to a certain degree understandable, despite the fact that we are not happy with it and that it harms actually patients not to use all the possibilities that Professor Miličić has presented to you and which are available for our patients. Again, I have also to say virtually free. Of course, nothing is free. We all pay this through taxes and all other forms, but the patients do not have to pay substantial sums of money, which they do have in a number of countries.
Professor Reiner, we mentioned earlier early coronary artery disease. Its most common genetic cause is familial hypercholesterolemia. Can you tell us something about that disease, prevalence, mortality?
Well, it's the general prevalence of familial hypercholesterolemia is based on actually those countries, European countries primarily, partially South African Republic, but primarily European countries who have good registries. Between 200 and 250, 1 to every 200 or 1 to every 250 inhabitants, meaning that this is the most often metabolic disease, genetic disease existing actually in humans. So at the moment, if we are talking about Croatia, we estimate the number somewhere between 16,000 and between 20,000 patients. However, most of these patients will not be, or at the moment, I hope the future will be much better, but at the moment are not recognized as such, and even more important, are not treated adequately. Why is FH, familial hypercholesterolemia, so important? About 50% of these patients, if they are not treated, have some coronary event, mostly myocardial infarction, unstable angina, need for coronary intervention or stenting or something like that in the age younger than 50 years. And about 85% at the age less than 65 years. So every fourth patient with FH who has an unrecognized and inadequately treated disease dies because of a coronary event before his or her 50th year of life. So it's a deadly disease which is under-recognized and undertreated. And this is the main problem, not only in Croatia, but I would say all over the world.
Mm-hmm. You said some countries have a registry, but am I right? Did I get it correct? We are not the one of that countries. We do not have any registry of this.
Unfortunately, that's true. We are starting with the registry now. We have a sort of, I would say, core of a registry with about 100 patients in it. We are working of course, to expand this registry, but we are very far from countries like Netherlands, which is definitely number one, which has at the moment, I think, more than 80% of FH patients recognized, treated, and so on. Very good results have also Iceland, Norway, Czech Republic. Much less successful in these are UK or Switzerland, and most of the other countries actually have recognized less than 1% of FH patients. So we are trying our best to develop the registry, because registries are something that really can help, because they force you also to do to screen the population, the target population, and there are different ways, of course, of how you can do this. Is it cascade screening like the Dutch have made, or is it some other form of screening? But anyhow, screening of the target population is crucial to find new cases and to try to treat them as early as possible, because this is extremely important, since these patients do have increased bad LDL cholesterol levels from their birth. And we know that the longer is the period that you live with very high LDL cholesterol levels, the greater is your chance to have a cardiovascular event.
Mm-hmm. But we are preparing. We are preparing for the registry. Screening.
Yeah, we have a sort of core of registry, and we are expanding it, and I hope that we will have a registry. Yeah.
Okay, but do we maybe have some target, like we heard at the beginning of this roundtable some numbers regarding cardiovascular diseases in general, but for FH that you're talking about now, do we have any target what we need to achieve in the next 1 to 5 or 10 years?
Of course, the ideal situation would be to find all the FH patients and treat them properly, and to treat them to their target values, to their target LDL cholesterol values. And when we are talking about FH patients, in primary prevention for FH patients, and they are per definition at high risk, high cardiovascular risk, their LDL cholesterol should be less than 1.4 millimoles per liter, or if you want in other measures, less than 55 milligrams per deciliter, and less than 50% of their baseline LDL cholesterol value. However, this is only for those FH patients who do not have any other cardiovascular risk factor, which is very rare. Most of our patients do have at least one, or some of them more other cardiovascular risk factors. For those patients, since they are at very high cardiovascular risk, LDL target should be lower, and it should be also. We should also achieve reduction of at least 50% of their initial LDL cholesterol value. So we have two different targets: 1.8 for those without any other or less for those with any other cardiovascular risk factor, or less than 1.4 for those who have more cardiovascular risk factors apart from having familial hypercholesterolemia. It's extremely important to treat them appropriately, which is not the case, not only in Croatia for most of these patients, but also all around Europe. We know these data from Eurospar surveys that we have also participated in and that we have repeated every 5 years, seeing, particularly in the last one, that among patients with proven cardiovascular disease, between 8 and 10% are familial hypercholesterolemia patients.
Those are high numbers, 8 to 10%. Yes, okay. Mr. Ahmad, can I ask you please, what can you tell us your opinion how healthcare systems can answer to this high burden of cardiovascular diseases?
Yes, thank you. So firstly, I think healthcare systems have been doing a tremendous job over the last couple of decades in terms of managing cardiovascular disease. I think Professor Miličić kind of articulated this. Certainly in the early 2000s, late 1990s up to about 2010, we've seen a significant reduction in cardiovascular death globally. It's somewhat plateaued in the last 10 or so years, to the point we are today where approximately 45% of all mortality within Europe is as a result of cardiovascular disease, and Professor Miličić mentioned 42.5% in Croatia. But the burden of disease is really articulated in the following fact that globally, still a third of all cardiovascular deaths are amongst people between 30 to 70 years of age. So these are still people very much in their prime, very productive. And there is an opportunity, I think, for healthcare systems to work in a more integrated way to reduce cardiovascular risk and ultimately prevent events. So as a company, that's something that Novartis is very interested in. One of the challenges in healthcare systems having to do this is you still need transformative therapies to support the healthcare systems and support medical professionals in this. There's an economic challenge to pharmaceutical companies. So I think it was mentioned by Professor Miličić earlier that there are various treatments in the last 20 years that have come out, products like statins, ezetimibe, which have provided LDL lowering and also had an impact in terms of outcomes. For a company like Novartis, for any company, one of the challenges in cardiovascular disease is to do outcome trials in this area requires really large patient groups. It's long duration, so there's certainly a significant investment, substantial investments that need to be made. Because we have some very effective treatments today, many of those which are now generic at quite affordable price points. From a health technology standpoint, demonstrating cost effectiveness versus current standard of care with the current methodologies that healthcare technology assessment agencies use is a bit of a challenge. But that's one of the ways where I think we can partner more effectively, I think, with healthcare systems to recognize the value of treating cardiovascular disease, but also translating the value of modern medicines. Because as I said earlier, this is not just about preventing events and the health economic benefits. The broader economic benefits of treating large populations of patients, many of whom are of productive working age, is very, very clear. So one of the things that we're doing as a company is we're exploring what we call population health type agreements with healthcare systems. So this is not dissimilar to the vaccines model. If you think in vaccines treat large populations of patients. The vaccines kind of engagement model is about how do we prevent progression of disease? Because if we can invest in prevention, that's where the healthcare system is going to get the greatest benefit. So one of the ways that we are doing that across the world is we're going to healthcare systems, and Croatia happens to be an interesting system that we will engage with in some discussions. Where particularly if there's a single payer or there's a single healthcare system, we'll say, well, how can we work together to recognize a really quite large population of patients? We could risk stratify this population, identify which population of patients are most at risk, and how can we work in partnership in the same ways that vaccines companies do with healthcare systems to prevent progression of disease in a much greater group of patients, where upfront we discussed the number of patients that potentially would be eligible, what the financial budget would be that provides financial certainty to the healthcare system. It also provides financial certainty to a company like Novartis. And we're doing exactly this actually in the UK. So with NHS England, we've actually signed a population health agreement in ASCVD, so for atherosclerosis, for managing lipids. And a partnership where we're targeting to treat many hundreds of thousands of patients with a transformative therapy that Novartis is bringing up, but we're doing this from the beginning with a goal to save 30,000 lives over 10 years. So what we've done as part of this agreement is we've identified an eligible population, which can be identified using the electronic health records in the UK. We've set some very common goals. We found ways to identify those patients, recruit them into the healthcare system, into this treatment program. But we've also submitted our price assessment to NICE, which is the National Institute of Clinical Excellence, the health technology assessment agency in the UK, the reimbursement body. And they can provide kind of, assurance to the healthcare system, to payers, that the medicine is cost effective, it's a good use of taxpayers' money. And in parallel, we're also doing something called implementation science. So this is kind of real world evidence at the same time, where we're assessing if this treatment and this population health approach, if it's delivered by healthcare professionals, well, physicians, nurses, or even pharmacists, which one provides the greatest level of patient experience, is the least expensive for the healthcare system, and provides the overall best kind of impact for the system. So they're some of the ways that we're looking to really partner with healthcare systems to treat cardiovascular disease on a much broader scale than perhaps pharmaceutical companies have done before, because I think if we're going to solve the greatest healthcare challenge in humanity, it's going to require governments, industry, and populations together to work together to address these biggest challenges. And we're certainly happy to participate in this way, and it's something that we'd be looking to see if there's opportunities to do something similar in Croatia.
So working together is the key, may I say?
Absolutely. I think within all healthcare systems, not just with the pharmaceutical company, but whether it be the payer, providers, other kind of societies in between, there's a much greater need for integration within our healthcare systems and how we work together.
Mm-hmm. Thank you, Mr. Ahmad. And Mrs. Arts, please, as the head of Novartis Foundation. What Mr. Ahmad mentioned, population model. Can you tell us some details? Novartis Foundation is working on population model exactly for cardiovascular diseases. What it is about? Can you share us maybe with more details, some examples?
Sure, thank you, Ivana, and it's a pleasure to be here with all of you. And I really enjoyed your view and your insights on Croatia, Professors Miličić and Reiner. It's really impressive, your advances. As Haseeb said, the cardiovascular progress has been massive. The Novartis Foundation as an organization is independent. We are funded by Novartis, but we are an independent organization that has no business objectives. But our goal is to advance data and digital-led initiatives to cardiovascular population health and help health systems around the world transform from being these reactive care systems to become more proactive, predictive, and even preventative, so that they really keep their populations healthy. And we do that primarily at the moment in low and middle income settings, because premature deaths are really mostly occurring in low and middle income settings. In fact, 80% of all cardiovascular deaths happen in such settings, and 75% of all the premature deaths being before the age of 65 happen there. So what we've seen around the world is that cities, urban settings are really drivers of such population health approach. And we set out to try that out in pioneering initiatives across the world going from Sao Paulo in Brazil to Dakar in Senegal, to Ho Chi Minh City in Vietnam, and Ulaanbaatar, the capital city of Mongolia. And what we did there was sit down with the local health system, the local authorities, because it's very important. The local health system leaders are in the driver's seat of such initiatives, as Haseeb was saying, because that creates the sustainability, creates the alignment in the goal towards improving cardiovascular health. And then we brought together multi-sector partners to address the problem of hypertension. We chose to work on high blood pressure first, as that was, still is the main killer around the world. And in most of the countries I mentioned, they are patients with high blood pressure are not detected, just as you were talking about the familial hypercholesterolemia patients. They are undetected and go forward in life without knowing they are sitting on a time bomb. So for hypertension, we chose that because it's relatively easy to diagnose and relatively easy to treat. So we know, then we brought together the health sector and other sectors such as food and agriculture, the sports sector, the education sector, the IT and tech sector, to also address the underlying determinants of which we know influence cardiovascular health much more than the health system only, being the physical activity, the healthy food, less tobacco and alcohol, and all the things we know. So with that, we changed the way health system managers and leaders were handling the problem. In fact, by measuring really very specifically the outcomes and the progress of the initiatives. So we measured everything we do, and it was in some places the first time health system policymakers were using data to base their decisions on, to then address interventions where needed, and reshape the whole initiative if that was needed based on these data. And I can tell you, in a very few short period of intervention where we focused not only on bringing health and care closer to people, we were engaging patients to take more responsibility in their own health by using digital health and mobile phones to create that engagement with the health sector. We used screening outside of the brick and mortar of the health system because people in such cities don't have time to go and sit and wait for the half a day to get their blood pressure measured in the hospital. So we introduced screening in the shops, in the manicure salons, and the barber shops in Ho Chi Minh City, for example, in the post offices, pharmacies, of course, and bus stations in Sao Paulo. And we identified hypertension much earlier than it was done in the current health system. Also, systematic screening in the health system at primary level wasn't present, so we introduced that also at the primary care level. In 1.5 years, only 1.5 years in a city like Sao Paulo, I will give you these results as an example, we achieved in a public health system that is pretty well functioning as compared to many others in the world, because they have free care available at primary healthcare settings, because the Brazil government had a policy like Croatia of a very strong public health system and giving freely access to treatment for everyone who needs it. In a relatively well-functioning public health system, we increased blood pressure control rates by 3 times. So we tripled it from 17% to 60% in 1.5 years. And we doubled the people under treatment also in that same period. So that translated in a reduction of strokes, the heart outcome we were measuring. We didn't measure myocardial infarctions, but 30% of strokes less. And it translates in a reduction of 125 deaths per 1,000 people treated if you extrapolate over 10 years. So massively impressive results for a city like Sao Paulo at population level, with just working on early detection, bringing health and care close to where people live, work, and play. So we also engaged the whole workplace, associations for health and safety in the workplaces. And that resulted in these fantastic improvements for cardiovascular health. So based on these data, I say in the meantime, of course, during that same period, COVID happened, And Sao Paulo was at the epicenter of the COVID epidemic in Latin America, if you remember in the beginning. So the state government asked us to work with them on the data lake they have in their university hospital in Sao Paulo, which is the largest hospital in the world. So it's a huge hospital with a massive data lake. And we used that and we strengthened that into an AI nucleus where we localized the image-based diagnosis from COVID that were successfully used and developed in China, brought them over to Brazil for use and localization in the Brazil population. It helped diagnosing COVID much faster at that time in the beginning of the pandemic. And that created this AI nucleus, as I say. So now with all the data on the urban cardiovascular health, we did purely at primary level, primary care level. We didn't collect data from secondary and tertiary care, but primary care data. We built that data lake together with partners like Microsoft AI for Health, who's helping us with the machine learning. We are now guiding the policymakers in Sao Paulo to take to identify those interventions that can have the biggest impact with machine learning and AI-driven tools to risk stratify their populations, who they have to allocate their scarce resources to, and get even better in their cardiovascular population health approaches. So that said, it's one example. Ho Chi Minh City is another example with similar results. When the city is so successful, it becomes easily scaled nationwide. So in Vietnam, that's what happened. In fact, the Ho Chi Minh City model has been scaled in national policy and is going through the whole country now. We hope to see the same in all the other countries where we work. And that's where I come with the question to Croatia, whether this would be an approach that would be of interest to you to work at an earlier level than before people get sick, to identify people as early as possible, not necessarily only for high blood pressure, but also for high LDL-C, because our next phase is obviously aiming to lower cardiovascular risk overall, not only on high blood pressure. If we can identify people much earlier, use data, a real minimal essential set of data collection to measure progress and outcomes, and then use machine learning on that to develop AI-driven tools that can help you take the right decisions, would that be a kind of approach that you would like to step in the boat with someone like the Novartis Foundation? In which case, I would love to learn how we can further the discussion.
Thank you, Mrs. Arts. You just asked the question I supposed to our professors. Professor Miličić and Professor Reiner, please, population health model. We all heard the results in really short period of time. I mean, Sao Paulo in Brazil. You, Mrs. Arts, you were talking about year and a half only.
Yes, it's true. And the same for Ulaanbaatar, Ho Chi Minh City, 2 years, similar results, transforming the primary health system,
okay, so
how they address the cardiovascular.
Yes. Professor Miličić, can we hear you first? What is your opinion on the population health model? Is it possible in Croatia?
I'm really impressed. That's great. And that's great that these advances have been achieved in a relatively short time. In Croatia, we are also having similar ideas, but and we are doing something, but we don't measure outcomes. I think that is at the moment our leading problem. We have founded Croatian Heart Foundation, which is a member of European Heart Network, and that foundation is quite an active one because it has developed two strategies. One strategy is e-educational platform for the patients and for the citizens to be properly educated about the impact of cardiovascular diseases, about the fact that they can be preventable. We are focusing on hypertension, lipids, diabetes, and lifestyle, food, tobacco, exercise, alcohol, etc. And another way of doing is that we organize some public activities, blood pressure, early diabetes detection, for instance, in some occasions. And we organized that on squares, supermarkets, places where people are gathering together, not only on the World Health Day, but on many other occasions. We even go to schools to educate children about the necessity of cardiovascular prevention and keeping their heart healthy. And probably we did something in that way, because my impression is that our population is more aware about these things that it was 10 years before. We have some impacts on cardiovascular mortality. We were talking at the beginning, probably not directly related to what we are doing, but we are helping, I think, in a way to improve things. The greatest thing in that Novartis Foundation activities was that probably it was much better structured, and it was focused on not only action, but outcomes evaluation. And that is very important. If you do something, you need to analyze the outcomes after a certain period. So that is what we miss. Because of course we miss more structure, we miss more resources to do all these things. We are doing that completely on voluntary basis, together with GPs, together with medical students, together with, of course, our cardiologists that are interested in these problems. But yes, I think we could do it much better. And that was really a great example how to change things.
Mm-hmm. And Professor Reiner, what is your opinion on the population health model? Is it possible? Can we build it in our country?
I fully agree with Professor Miličić, and I'm also impressed with achievements in such a very short period, just 1.5 years. I would like to stress one aspect of it, and this is raising awareness of the problem. Because I think that looking at different parts of Europe, let's concentrate at the moment only on Europe, not other continents. We have some countries that have reached the plateau. They're usually richer countries where the awareness about the problem of cardiovascular diseases and cardiovascular mortality is relatively high. However, it has reached a plateau, and the plateau level is not something that we should be happy with. Then we have another part, particularly Central and Eastern, even more Eastern Europe, where the awareness on cardiovascular diseases and cardiovascular mortality is much lower. We have done some 10 years ago, of course the data are old, but we have done surveys in Croatia about the awareness of different subpopulations, general population, medical doctors, different specialities, GPs, cardiologists, and internists, and so on, and then medical students at the beginning of their study and at the end of the study. And we've published several papers on this. And at that time, we had much higher incidence of cardiovascular diseases, I have to say, but it was very interesting to see that people, general population, is much more afraid of malignant diseases than cardiovascular diseases. Although at that time, every second Croatian citizen died because of cardiovascular diseases. The number was 52% at the highest moment. And at the same time, at that time, only about 25% of them were dying because of malignant diseases. However, they were incomparably much more afraid of malignant diseases than of cardiovascular diseases. Again, going back in more richer, let's say, Western countries and so on, the approach towards cardiovascular diseases caused by atherosclerosis has become a little bit twisted, I would say. People think that due to the fact that you can have a myocardial infarction and you go to the hospital and then you get your stent and dilatation, and then several days later you can be back at your work, that it's like nothing, that it's like taking a candy. So they do not pay appropriate attention, I would say, to the secondary prevention, that they have to take care after they have survived an event, that they have to take care even more about all risk factors and so on. But going back on the central and eastern part of Europe, the general awareness is still much lower. For instance, again, comparing with some other disease in Croatia, if you would ask people whether they're afraid of HIV infection, which is in Croatia, from the point of epidemiology and from the point of spreading the disease, neglectable, totally neglectable. We do not have a problem of HIV disease on any important level. They would say, yes, I'm afraid of HIV disease. On the other hand, they are not afraid of cardiovascular diseases, which kills almost every second citizen. So this awareness and perception is also something that we have to work on all together. And I think this model of foundation combined with raising the awareness of cardiovascular diseases would be fantastic.
Thank you. I think you're absolutely right. And we've seen, as you said, Professor Miličić, you have to organize events to do the screening for the risk factors. We have, with our data from all the cities combined, we have done a business case also to see what are the interventions that deliver most impact on the outcomes, on social impact. And in fact, the systematic screening, like we did, we reached out in the main football clubs in Brazil. You can imagine how many young guys come to the football matches that never come to the health system. We did screening during match days, and we went to the samba schools and all these local cultural events that they have, and there you gather a lot of people and get the opportunity. But the most impactful interventions were installing screening corners in every primary healthcare center, because so many opportunities are lost for people who present in the health center for their kids or their mother or father, and they can get their blood pressure measured there as well. So it's a real good opportunity to increase the number of people that you detect the problem for. And then working, as you mentioned, in schools and workplaces is very, very instrumental to achieve that awareness and perception, but also to identify people earlier. In fact, in African children, we find 25% of the under 12 have hypertension. It's really scary. So there would be really interesting results if you start measuring that systematically. So I would love to have that conversation, if it would be possible, and follow up with you both and see how we can work together. For us, it's very important the local health authority remains in the driver's seat. So it is, most of the interventions are done with local resources. What the Novartis Foundation brings are the innovative parts, like maybe how we can measure or how we can use digital tools to transform the way patients are engaged, or patients are knowledgeable, or health providers are trained with electronic CME, as you mentioned. So that's the things we would finance. But the bulk of the interventions of improving the health system performance, it's in the hands of the local authorities. So that's it. Yeah.
I think you could really help us with your methodology, because the methodology is excellent. When I was listening to you, then it occurred on my mind that we have other thing in Croatia, which maybe doesn't exist in some other countries, that
Yes.
employees, regardless whether they are in public system or in private system, they usually go yearly to medical checkups.
Oh, wonderful.
Yeah.
Yeah.
It is called systematic checkup.
Yeah.
And then they have an opportunity to, in fact, be measured regarding their cardiovascular risk. So maybe raising awareness in that direction to try to be more persuasive to all these healthcare professionals and people who go to these checkups to be aware of that fantastic possibility to get data on cardiovascular risk and to start acting. That should be one of way to improve things.
Yeah,
because
absolutely.
That is already a nice tool to get some data and to try to change things.
I agree. Wonderful.
Yeah, for instance, on these checkups, they measure cholesterol, they measure blood pressure, and they give some recommendations. But I think these recommendations are not too strong. And the main idea, people have a perception about these checkups is to exclude malignant disease and to exclude any serious disorder. If they find hypertension or, I don't know, LDL above upper limit, so that is an information, but usually they get a recommendation, you know, change your lifestyle, or maybe try to take statin, or try to regulate your blood pressure, or go to your doctor and control it. And, you know, they forget that. They're happy, oh, I don't have any serious disease at the moment, and that's it, I'm healthy. So we have maybe to act also through that pathway, which could be effective. Mm-hmm. And with all the activities you have mentioned, we have pharmacies, we have many other institutions that can help us to include more population in these preventative activities.
Wow, that's great, yeah. Thank you.
Maybe stressing the issue of familial hypercholesterolemia. There is a proposal that I'm pushing for some time, so far not very successful. But we have also something that is compulsory, and this is that children entering primary school do have their also sort of checks, basics exams. And this is a moment where they could do cholesterol testing because they are tested for anemia, they are tested for for glucose, and so some basic things. And actually, cholesterol is not an expensive thing. Unfortunately, we do not have many children. The number is going down. Unfortunately, we are a population that is getting older and older, and our birth rate is going down, unfortunately, due to many circumstances. So it wouldn't be very expensive to check every child who is entering the primary school and to detect then FH patients.
Mm-hmm. Mm-hmm. May I say
many opportunities? Eh?
Yes, many opportunities. You have detected problems, but I already hear some solutions for Croatia. So before I wish us all luck, I would like to, for Mr. Ahmad, who is listening all of this very carefully, can you give us some conclusion, maybe some recommendation after we hear our professors? What are the Croatian main problems at the moment?
Yeah, I mean, I see some common themes coming out of here, and that, I mean, there's a clear understanding that in many cases there are clinical solutions that are required. Medications have a big impact, but integration of care is really going to be what is going to really drive the system forward. And that, from the foundation perspective, I think we have some, you know, really interesting ideas that are applicable in any healthcare system when it comes to primary prevention. And then on the other side, which is secondary prevention, there's other ways in which a healthcare system and a private pharmaceutical company potentially on the commercial side could collaborate as well. But to do that right across the system where we're driving clinical behavioral change, but also patient behavioral change, that's what's going to really make the difference.
Okay, so we know what we need to work on. I thank you all of one. I wish to thank you, all of you, and all the best with this and everything else. Thank you
very much.
Thank you so much. Nice to meet you.
Nice to meet you too.
Nice to
Thank you.
Bye-bye.